These slides were created in response to people coming up today and asking if we were going to talk about this. So I'm not an expert on this. These are slides that we created just today because we wanted to be responsive. We have talked about this in our lab quite a bit, and we've written a little bit about it, but I think it's a really important issue. And there was two geropsychologists, I hope he's still here. Yay. Okay, so I'm going to call on you to talk a little bit about what your folks from ethics said. Are you game for that? Not that you really have a choice now. Sorry. So, okay, good. Okay. First of all, let's talk about hastened, right? Hastened means you're making it happen faster, right? And we're talking about this in particular here because why? Yes, you have particular state laws that make this a unique situation for you all as care providers. And one thing that's really important to know, and I think this is highlighting this point, is that decisions regarding death are impacted by the society and the social beliefs of where we live, right? And there's some places in the United States where this would not be as much of an issue because the idea that you could choose to end your life would not be wouldn't be voted on. Let's just say that. Probably would not be voted on at this point. But the fact that it has been here says something, hypothetically, about the beliefs and values in Washington State and in other states. I won't make the marijuana connection also, but we have marijuana but no end of life. I guess you guys have both. So I don't know what to say about that. Anyway, and this often comes up, right, related to when people have, particularly I've looked at it around neurodisabilities. So things like ALS, MS, Huntington's disease, it often comes up with cancer, where there is an end of life, a certain end of life, and in an amount of time, and the person is making decisions about ending their life early. Now, interestingly, I have a patient I'm working with. He has chronic headaches, and he and I have been in a very long discussion because he believes that chronic headaches is enough to make the choice to hasten his own death. And that's actually not what we're talking about here, right? That would be clearly in the suicide category, in my mind. We're talking about people who are at end of life and it is a known, there's no more viable treatments. This is a matter of time, and I think that's a really important thing for us to be on the same page about. So currently, there are 4 countries and 3 US states where this is legal. So you're in a very interesting company there. And because of that, like with the marijuana situation, this is a little bit of a social experiment, right? People, whenever I go travel around, people are saying, oh, you're from Colorado, how's the marijuana thing going? I'm like, you know, we're trying to figure it out as it goes. And I think probably this is true for you all with this issue. You're trying to figure it out as it goes. Now, all that being said, is the VA federal property or state property? Federal. So, as much as I love Washington and I love being here, I'm on federal property right here. And what does that mean? Federal laws. So, do VA physicians engage in this practice? No. And this is where I want my colleague, can you stand up? So, can you I should bring you the microphone. And I'm asking him because he's a geropsychologist, is that right? Do you know him? I don't know his name, but he's very nice. Do you know his name? Duh. Okay. Yeah. I have a case of a man with untreatable terminal cancer, and before moving to the state, was in another state without a death with dignity law, and had developed a very active plan with possession of means to end his own life before he got to the really bad state of this, where his quality of life would be very low. Moved to Washington State and
entered into hospice and palliative care with us as an outpatient. And he and I have had some long discussions about taking some sense of control, which is what he's really trying to do, and not wanting to die in a terrible way. And so the discussion became, how would you rather die by sort of a seedy kind of way, by killing yourself in the back room, versus physician-assisted suicide, and how would that, what's going to be easiest on your family? And so that kind of became a protective factor, was doing this in a way that, I mean, there's a lot of meaning making in how his last act as a parent and what he does for his family in this. So I consulted with our ethics people.
That's the part I really wanted to.
Yeah. So I.
You did a really smart thing. You already did.
Well, I panicked first. So after I panicked, I talked to the ethics people here. What I was told was of course, number one, don't abandon your patient. Don't say, oh, you want that? Well, gotta go. Let me know how it turns out.
Hey, Doc, can you speak up?
Oh, yeah, sure. So they said, don't abandon the patient. Of course, maintain a therapeutic relationship with him as a place where you can discuss objectively the pros and the cons of his desires and his goals and his priorities in his life. It's public knowledge that this is an option in this state. He's able to go out and find a provider on his own that would provide that if he so chose. You know, that I should just be very careful that I don't stray over the line of being just sort of an objective sounding board into slipping into the role of somehow an advocate or something like that. So my discussion with him around what would be better for your family is based on his priorities, not mine. And he said it would be better to do it the physician-assisted way.
Okay, so I think that's super helpful, and there's a lot of good points in there, but the point that I want to make sure that we make again and again is when these new issues arise, we have things like ethics boards that we need to use. And actually we need to document that we're using them, right? Because that is, again, back to protecting yourself, protecting your patient. Interestingly enough, and I didn't know this prior to writing a little bit about this, but there's like lots of different terms for different things. And so one thing I think for us to know is if we're going to talk about this with patients, we need to know kind of the language and what the different options are. So euthanasia is killing on request and is defined by a doctor intentionally killing a person by the administration of drugs at that person's voluntary and competent request. Okay, so the doctor has, or the physician has a very specific and active role in that. Palliative sedation, it's using sedation to engender sleep until death occurs among dying individuals, particularly individuals who are experiencing refractory symptoms like delirium and agitation, and when people are unresponsive to conventional treatment. So again, that's different, but does fall under this category of hastening death. And finally, physician-assisted suicide, and I think that's what's legal here, is that right? Yes. Okay, a doctor intentionally helping a person to commit suicide by providing drugs for self-administration at that person's voluntary and competent request. Is that's right? That's what the law here is. Yes? Okay. And these are not my definitions. These are like definitions that are out there by the real world. Now, whether this is suicide or not, I do not actually want to go there today, in as much as have this conversation and know that this is somewhere related to the larger conversation we've had today. Okay? Interestingly, I think in terms of the physician-assisted suicide, in terms of those folks here that are in rehab, some very interesting issues come up when folks have limited mobility, when folks don't have use of their upper extremities, and how can people engage people that are kind of needing care to do things like eating, how could they engage in this behavior? The other thing I really want to highlight is this idea of voluntary and competent, right? So you're choosing it and you're competent to make the decision to choose it. So again, this brings us back around to the idea of autonomy. In your state, the voters have decided that this choice is a reasonable part of autonomy. And it also then poses some serious ethical dilemmas for providers and healthcare systems. And one of the main things that we are trying to do as mental health professionals is help individuals differentiate between being depressed and having existential suffering. Does that make sense to people, the existential suffering piece? Okay. And so one key point as a mental health professional in your documentation is going to be clarifying if this choice is being made out of depression. If there's depression, or the person is more existentially done with living. And again, it's really important to note this is in the population of individuals with end-stage disease, right? And most of us in this room, we don't need to make that choice about end-stage disease, right? Some other kind of professional makes that choice. But it needs to be about end-stage disease, like I said about my patient with bad headaches. Bad headaches really suck, but it's not end-stage disease. And the other thing is, as we've heard a lot today, this is something you want to think about ahead of time, right? You don't want to be called in on a consult tomorrow with a patient and never having thought about this before, right? And if you don't spend time thinking about this, this will inevitably come up in a clinical setting, and you will not be prepared for it. And this is not, I mean, even no matter how you feel about this, this is not an easy clinical conversation to have. The more we can prepare ourselves to respond professionally and I think compassionately, regardless of how you feel about this. I am aware that people in this room, if I took a poll, people might feel very differently about this for themselves, for their family members. I know that there are people in this room that there's certain conditions they can imagine living with, and there's other conditions they can't imagine living with. Right? Everybody's kind of got their own deal with end of life. But regardless of what your deal is, and your deal may be that you believe that this isn't your choice to make, that's a deal too, that you need to be respectful and compassionate with patients around this. And so there are some folks who've provided guidance for us about how to do this. And I think one of the most important things we can do is understanding, you know, the meaning behind the choice or the stated desire. Why do people want to do this? And in specific, that they can explore issues underpinning the statement and identify critical clinical issues, and finally discuss the interpersonal factors involved. And I think we heard before about the interpersonal factors piece. Okay, this may kind of work for you. How's this going to work for your family? And again, as people talk about things, being really alert to your own responses, right? And this is that kind of when you're talking to somebody clinically and you feel just the heat rising, or you feel like you in your head you're thinking, I can't believe this person's saying this, or all the different things that happen to us in a clinical hour. Just being really aware of your responses to it. This is an article that I really like, again, by Hudson and colleagues. I'll be happy to put the citation in the slide so people can see it. And I'm not going to go through this today because I know we're getting close on time, but I just wanted to make sure that you all knew that other people have thought about this. And they have a series of steps that they recommend with very specific things. And actually what I've done is I've copied and pasted this into like a sheet and just brought it with me into the room before. Right? And just go through the steps. So the first is just being aware of your own responses, monitoring your attitudes and responses to desire to die statements, and again, consultation. Being open to hearing concerns about the patient, and you can really listen to people's desire for death without actively supporting that, without saying, yeah, I think that's a great idea. Right? And trying to really work ahead of time on what is that line. I respect you, I respect this is meaningful to you, that doesn't mean I agree with you. And practicing that bit ahead of time. I think the thing that we can certainly match as mental health professionals is how hard something is or how sad something is. So going it more at the level of affect than content. Yeah. Oh, more evaluations. Hi, I'm Dr. Brenner. And you can reevaluate me well, right? As you ask for more evaluations. All right, no, there they are. All right, sure. The next thing is identify potential contributing factors. And again, I just highlighted the one here about the psychological distress or existential distress. And I think this is key. Is this person suffering from anxiety? Are they suffering? Are they in pain? Or are they done? And what would that look like for them? Really assessing for any unrelieved symptoms. So again, are there things that could be made easier in terms of their environment, in terms of accessing the bathroom, accessing food, help them save dignity, and also address pain. The other thing is also just assessing interpersonal conflicts, and this includes staff, right? There are patients on our units that the staff is challenged by, right? And we need to understand if that's contributing to people's desire to die. If they're getting the message from people that they are too much to take care of, that it's just too difficult, that's an issue. Finally, responding to specific issues that the patient brings up, addressing any potential reversible causes and planning for referral or continue to see them about this. And then finally, concluding the discussion, summarizing the main points and really providing the patient with a clear idea of what the next steps are going to be. It's your job then to talk to the other treatment team members. People, MDs, sorry there's no MDs in the room so I can just say it, but MDs often, particularly non-psychiatric MDs, don't like to talk about death that much, right? So when I used to work on a consult service, when they would find out somebody was dying, they'd call the psychologist, right? And they'd say, can you talk to them about that they're gonna die? But we need to help teams talk about this and find ways to provide information to veterans about their options. And also really helping the veteran talk to family members. Again, this doesn't mean that you agree with the decision. It means you're using your clinical skills to help try to facilitate a discussion amongst family members. And finally, I think we've said this many, many times today, documenting the discussion. And certainly if I was documenting this kind of discussion, I would take my template, I'd put it in the note, and I would say that I did these steps based upon this article you could do, and you have done evidence-informed practice, you have documented that, and you've kind of covered yourself in many different ways so that you can feel, again, less fearful. I know this was very quick, but I hope helpful just in terms of thinking about there are, again, resources out there to help you. You don't need to figure this out on your own. If we had time, I was going to give you a case, but I'm not going to give you a case. This is a long and very sad case. But when we post these slides, you'll see this link. This is actually a really great article about hastened death, choices that people make, and it has several different case examples of what happens to the cases and presents a lot of the issues in more detail. So that resource will be there for you too. I'll talk for 1 second about how great the postdoc is at the Visit 19 MIRAC. I know there's a lot of trainees in the room. Come to our MIRAC if you're interested in suicide and suicide prevention. We're recruiting people for next year for our 2-year postdoc, mostly focused on research, but also obviously clinical care. And the main thing at the end here is the VA does have a lot of resources. The VA has challenges with some things, but they do provide lots of resources. The part of the problem is sometimes we don't know about them all, right? So make sure that you leave here knowing about the crisis line. I think you know about the consultation service. I talked, there was some concerns that this is actually hard to, you have to fill out a lot of paperwork and stuff. You don't. If you just call this number or email the srmconsult@va.gov.org. It's missing something. Or. I'm like, oh God, oh my God, I need to stop now. Okay, I'm like, that's not right. Sorry. Anyway, that's all. So, thank you all.